بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will handle the topic of MRI of the ankle and foot, and this topic will be presented on two parts. The first part will deal with the ankle joint, then the second part will be totally handling the foot lesions. Then, as you all know, that in order to image the ankle, or any joint in the body, we can have this by the plain X-rays, by CT, by MRI, and also by ultrasound. In this topic, we'll handle the role of MRI in assessment of the ankle lesions. As you all know, we have more than one MR machine, including the closed MRI and the open MRI, the extremity MRI, which is suitable for evaluation of the elbow and wrist joints, as well as evaluation of the knee and ankle joints. And this is just an example of an extremity MRI and how can the patient uh, is prepared for the examination by putting his ankle in the machine. And you know that this machine is very good considering the resolution, since the surface coil is the coil of the magnet itself. Then, in order to examine the ankle, which would have a surface coil, and these are examples, and we should select the field of view for suitable for evaluation of the ankle, and this field of view should range between 8 and 12 centimeters. If you enlarge the field of view, the images will be very small. If you reduce the field of view, you may miss some of the anatomy and pathology in the images. Then we should have, in the protocol of the ankle joint, we should have axial, sagittal, and coronal, including the T1, T2, the gradient, and the stair images. And recently, you know that we have the dynamic MRI, which enables the examination of the patient while weight bearing. And this is very important for the spine, the hip joints, the knee joint, as well as the ankle joint. And sometimes we are able to examine the patient while walking by moving this sheet underneath the foot of the patient. Then, in order to know the pulse sequence, you should look for fluids. If the fluids are black, and this is T1, if the fluids are bright, and this is T2. But if no fluids are present in the image, like in this ankle joint, if there is no joint effusion, then you can use the fat as for judgment of the pulse sequence. If the fat is bright, and this is T1, if the fat is gray, and this is T2, if it is more dark, and this is T2 star, if it is very dark, and this is their images. Both the T2 and also the T2 star and the stair images belong to the T2 weighted images, meaning that the fluids will appear bright in these three images. Okay, and you know from the previous lectures that the structures that show low signal in the T1 and low signal in the T2 weighted images include the cortex of the bone, ligaments and tendons, and calcification, because they have no mobile protons. I am sorry for this mistake, this should be low. Then the structures or the pathology, which shows low signal in the T1 and high signal in the T2, and this is fluid. And fluid is present in the fusion, in the cyst, in the articular cartilage. And if you look here and you see fluid in the retrocalcanean bursa, which is black in the T1 and bright in the T2 weighted image. The opposite of fluid is the fat, and then the fat is high in the T1 and low in the T2 weighted images. The fat is present in the subcutaneous tissues, in the bone marrow, in the dermoid cyst, for example, and so on. Then one of the good policies to handle the ankle joint from both the anatomic and pathologic points of view is to imagine that the ankle is a four directional joint, and we have the posterior aspect of the ankle, the anterior aspect, the lateral, and the medial aspects. And every part of these four directions, we should look for tendons and ligaments. And after finishing these two main issues, then we'll have few other points in the ankle. Then we can finish the whole story. Starting by the posterior aspect of the ankle. These are the some of the few points that I will handle after finishing the issues of the tendons and the ligaments in every compartment as I mentioned. Starting by the posterior aspect of the ankle and considering the tendons and ligaments, we have only one tendon and no ligaments. The tendon is the Achilles tendon, and this Achilles tendon is attached to the posterior aspect of the calcaneus. It is one of the strongest tendons in the body. Is best evaluated in the axial and also in the sagittal images. In the axial images, it is present here, subcutaneous. The posterior border is convex, the anterior border is flat or sometimes concave, and the tendon is not normally rounded. If the tendon is rounded with convex anterior border, it is pathologic. Then this is the strongest and largest tendon in the body, but it is commonly injured because of its superficial location. It lies immediately subcutaneous. The tendon has no tendon sheath, meaning that there is no tenosynovitis of the Achilles tendon. It has a flat or concave anterior aspect as seen in the axial image, and there is a small bursa anterior to the tendon insertion between the tendon and the calcaneus known as the retrocalcanean bursa. The normal appearance of the Achilles tendon is of uniform low signal in all pulse sequences, provided it is normal. Then, what are the lesions that can affect the Achilles tendon? First of all is rupture. And rupture of the Achilles tendon may be complete or partial, and this occurs at the point 2 to 6 centimeters superior to its calcanean attachment. And in about 25%, the rupture is clinically missed because of pain and the soft tissue swelling resulted from the trauma that has caused rupture of the tendon. Then, if you diagnose rupture of the Achilles tendon, you should measure the site of the rupture from its calcanean insertion, and you should measure the gap between the cut edges of the tendon. You know that normally there is a triangle of fat present posterior to the leg bones and anterior to the Achilles tendon. And this fat is known as Keger's bed fat bed. If this fat is obliterated, one of the possibilities is injuries or abnormalities of the Achilles tendon, as you can see here. One of the major tools in musculoskeletal imaging is ultrasound, and ultrasound is now one of the best imaging modalities for evaluation of most of the joint pathologies. Being a superficially located tendon, it can be easily examined by ultrasound. This is the normal intact Achilles tendon, and this is Achilles tendon with rupture. And then you see the gap between the cut edges of the tendon by ultrasound. But MRI is one of the well-known modalities for evaluation of tendon rupture. This is the normal appearance of the Geiger band of fat with an apparently intact Achilles tendon. But here you can see that there is disturbance of the appearance of the fat with the diffuse swelling of the region of the Achilles tendon. And in the MRI, you can see there is rupture of the Achilles tendon, let us say about 2 to 3 centimeters from its calcanean insertion, with fluids and a gap between the cut edges of the tendon. And this is also a rupture of the Achilles tendon in AC. In the gradient image, there is a gap, and this is the distal part of the tendon. Let us say 3 centimeters from its calcanean insertion, there is a full thickness rupture. And also, if you look carefully, you can see that there is diffuse swelling of the tendon, and this may suggest that the tendon is degenerated first and then subjected to full thickness tear. Then this is the normal appearance of the Achilles tendon, and this is the Achilles tendon rupture. You can see the gap about 3 centimeters, let us say, from the calcanean insertion, and the gap is filled with fluid. And you know that this site of injury is the most common site, which is about 2 to 6 centimeters from the calcanean insertion of the tendon. Also here, you see this is the distal part of the Achilles tendon. There is rupture and a gap filled with fluid, which is bright in the T2 weighted image, black in the T1 weighted image. The Achilles tendon is rounded with convex anterior margin, denoting that it is not a normal tendon. And whenever the Achilles tendon is avulsed from its calcanean insertion, and this is known as insertional tear. And you can measure also the gap between the cut edge of the Achilles tendon and the site of its insertion in the posterior aspect of the calcaneus. And by plain X-ray, you can also diagnose avulsion tear of the Achilles tendon whenever you see a bone fragment which is avulsed from the posterior aspect of the calcaneus and retracted upwards. And this is the site of the attachment of the tendo-Achilles to the calcaneus. And partial tear means that some of the fibers are intact and other fibers have ruptured. And the partial tear, you can see a fluid signal uh, inside the substance of the tendon, while other normal fibers of normal signal are seen along the course of the tendon. Then here you see this is the Achilles tendon, and you can see a focal area of increased signal near its calcanean insertion, denoting partial tear associated with some edema in the subcutaneous tissue and also edema in the fat anterior to the calcaneus, to the tendo-Achilles. And this is also an example of partial Achilles tendon tear. You see the torn fibers are replaced by fluid, and these are the intact fibers. Another example of insertional partial tear of Achilles tendon, the posterior fibers are intact, anterior fibers are ruptured and replaced by fluid signal. And if the Achilles tendon has ruptured many years ago, the site of the Achilles tendon may develop a dystrophic calcification, which may be later on transformed into bone. And this is known as a stoned Achilles tendon, which means that there is a long time passed since the rupture of the tendon. And there are some causes for the development of ossification of the Achilles tendon, like you can see here in the plain X-ray. The previous microtraumas to the tendon, Achilles tendon rupture, chronic rupture, previous surgery, and repetitive microtrauma. This calcification of the tendo-Achilles are more common than dystrophic calcification of the tendo-Achilles. They represent a separate entity rather than progression of the disease characterized by the formation of mature bone with cortex and trabeculae and bone marrow as well. Then we came to the Achilles tendon degeneration, which means that there are degenerative changes in the Achilles tendon. This will result in a swelling or relative increased caliber of the tendon, and you may got some faint intermediate signals within the tendon itself. And if you look here, and this is the increased caliber of the Achilles tendon with some intermediate signals within the Achilles tendon itself, and this is Achilles tendinopathy, tendon degeneration, or tendinitis. Another example of Achilles tendon degeneration, you can see that the tendon is rounded with convex anterior margin, internal intermediate signal within the tendon denoting tendinosis. Another example of Achilles tendinosis or tendinitis or tendon degeneration or tendinopathy, that Achilles tendon is focally swollen with faint intermediate signal within the Achilles tendon itself, denoting degeneration. Another example of Achilles tendinosis, the Achilles tendon is swollen and you see faint intermediate signal within the tendon with some inflammatory changes in the subcutaneous tissue as well as inflammation in the bursa anterior to the Achilles tendon. Then degeneration of the tendon may progress to partial tear and even to complete tear because you know that the tendon, whenever it is started degeneration, it is weak and is subjected to rupture. Then how can you differentiate between partial tear and the tendinosis? The signal of the tendinosis is faint intermediate, but the signal of tear is bright, similar to fluid. Then if you see that the Achilles tendon is focally enlarged with some faint intermediate signals within, and this is tendinosis. But if you see bright signal, similar to the fluid, and this is partial tear. And this is tendinosis that has progressed to complete tear. How can you know that this is tendinosis? Because of the significant increased caliber of the Achilles tendon in the T1 and T2 weighted images. If the signals are intermediate, and this is degeneration, if the signals are increased approaching that of fluid, and this is and this is tear, and in this example, and you can see full thickness tear of the Achilles tendon. You remember that Achilles tendon has no synovial sheaths, but it has this very thin membrane, which is known as the peritenon. Then Achilles tendon will not develop tenosynovitis, but it will develop peritendinitis. By Achilles peritendinitis, we mean that there is some inflammation of the soft tissues around the Achilles tendon, either deep or superficial or both. The Achilles tendon itself may look normal or may show some tendinosis, In such case, you got a slight increase in the caliber of the tendon with faint intermediate signal within the tendon. Then the retrocalcanean bursa is a small bursa between the Achilles tendon and the back of the calcaneus. Any bursa is not usually seen on imaging unless it is filled by fluid. And one of the causes of fluid in the bursa is inflammation. Then few drops of fluid are allowed in the normal bursa in the retrocalcanean area. But if you see too much fluid like this, means that this bursa is inflamed. Then if you got this triad, which means there is Achilles tendinopathy or tendon degeneration, retrocalcanean bursitis, inflammation of the retrocalcanean bursa, and inflammation of the subcutaneous tissues superficial to the Achilles tendon, and this is known as Haglund syndrome. This Haglund syndrome is very common in females who wear these very high heels, which put too much stress on the region of the tendon Achilles, resulting in inflammation of the tendon and also inflammation of the bursa super deep to it and the subcutaneous tissue superficial to the tendon. Then the triad of Achilles tendinopathy, retrocalcanean bursitis, subcutaneous inflammation is known as Haglund syndrome. And this is Haglund syndrome with some thickening of the Achilles tendon, some fluid in the retrocalcanean bursa, and subcutaneous edema superficial to the tendon, low signal in the T1 and high signal in the T2, forming the triad of Haglund syndrome. Then Achilles tendon xanthoma is an accumulation of lipid-laden macrophages, inflammatory cells, and giant cells secondary to cholesterol deposition in the tissues. This will result in painless soft tissue enlargement of the Achilles tendon bilaterally and maybe also some of the soft tissues of the foot and other parts in the body. The involvement of the Achilles tendon is usually bilateral and symmetric. It affects commonly the distal third of the tendon. And this can be differentiated from gout, for example, or tendinopathy, as I have mentioned, and some inflammatory conditions and maybe tumors as well. If you look to the brain X-ray, it is easy to diagnose this pathology by bilateral symmetrical diffuse huge enlargement of the shadow of the Achilles tendon encroaching on the Kager bed of fat. An increase in the AB diameter of the tendon because of the deposition of cholesterol, the, the tendon may show a slight increased signal in the T1 with decreased signal in the T2 weighted image. The tendon will be rounded with convex anterior margin. Then look at the MRI. This is quite different from Achilles tendinopathy. This is huge swelling of the Achilles tendon, and you may see some of the dots or faint intermediate signals within the affected tendon. And this is the xanthoma of the Achilles tendon, sagittal T1, sagittal T2, and sagittal stir. You can see the marked swelling of the Achilles tendon. And we finished from the posterior aspect of the ankle, and we discussed the lesions of the tendo Achilles, which included full thickness tear, partial thickness tear, tendinopathy, Haglund syndrome, and xanthoma of the Achilles tendon. Now we came to the lateral aspect of the ankle where we can see tendons and ligaments. There are two tendons and two ligaments. The lateral aspect of the ankle is identified by the presence of the fibula, and posterior to the fibula you can see the tendons. These are the peroneal tendons. The peroneal tendons include the peroneal brevis and the peroneus longus. If the tendons are adjacent to each other, then the medial one or the inner one is the peroneus brevis, the superficial one is the peroneus longus. If they are present behind each other, then the anterior one will be the brevis and the posterior one will be the longus. And these are the peroneal tendons which are located posterior to the tibia. The anterior and the medial one is the brevis. The posterior and superficial one is the longus. Both tendons have almost similar cross-sectional caliber. Usually, the peroneal tendons are located within a groove in the posterior aspect of the fibula in order to prevent the tendons from being dislocated laterally. Sometimes the posterior aspect of the fibula is flat, and this may lead to lateral dislocation of the peroneal tendons. And this is also an example. You see the irregular posterior margin of the fibula with lateral subluxation of the peroneus tendons. This is the longus and this is the brevis. Then if you look here, and this is the brevis and this is the longus, and here you can see the longus, but you cannot see the brevis. It is replaced by a large amount of granulation tissue, maybe hemorrhage and edema, meaning that the peroneus brevis tendon has ruptured. Then we came to the ligaments on the lateral aspect. We have two types of ligaments, the lateral collateral ligament and the syndesmotic complex. The lateral collateral ligament is formed of three bands which are arising from the fibula going to the talus and calcaneus. And we have the anterior talofibular ligament, the posterior talofibular ligament, and the calcaneofibular ligament. In order to identify the lateral collateral ligament, first of all, go to the fibula and then go to the section where the fibula contains a groove looking medially. At the level of this groove, you will see a ligament coming out from the groove, and this is the posterior talofibular ligament. If you look anteriorly, then you see this line, and this is the anterior talofibular ligament. The calcaneofibular ligament is not seen in its full thickness in the axial images, but it's important to identify the posterior talofibular and the anterior talofibular. The anterior talofibular is one of the constant ligaments and it stands by itself for the lateral collateral ligament, meaning that if we said that the lateral collateral ligament is injured or ruptured, then you mean that the anterior talofibular ligament is that which has been injured. This is the appearance of the anterior talofibular ligament is better evaluated in the axial images at the level of the fibular groove. This is the posterior talofibular and this is the anterior talofibular. In the coronal image, it comes from the fibula to the talus and it is about 2 millimeter thick and 2 centimeter long. The posterior talofibular ligament is seen in the axial image at the level of the fibular groove coming out from the groove to the talus. And this is the anterior talofibular ligament. This is the posterior talofibular ligament in the coronal image. It is better to evaluate the lateral collateral ligament in the axial images. Then, you know the golden rule for ligamentous injury. If any ligament is torn, then you expect that you do not see the ligament at its anatomic location and its site is replaced by fluid. Then normally you see the ligament and you look here, but in this case, then you do not see the ligament and its site is full of fluid signal, meaning that rupture of the anterior talofibular ligament. This is the normal anterior talofibular ligament, and this is the ruptured ligament. The ligament is not seen, and its site is occupied by fluid signal. Another example. This is the fibula, and this is the groove. You should see the anterior talofibular ligament here. It is not present. Its site is occupied by fluid, meaning that the anterior talofibular ligament is torn or the lateral collateral ligament is torn. And this is the level of the fibular groove. This is the posterior talofibular ligament. The anterior talofibular ligament is not present, and each side is occupied by fluid, meaning that it is ruptured. With the chronic ankle sprain, there may be diffuse thickening of the anterior talofibular ligament or the lateral collateral ligament, and this is known as chronic injury. The ligament will show almost normal signal, dark signal in all pulse sequences, but its caliber has much increased, and this is known as chronic injury of the lateral collateral ligament. Another example of chronic injury of the lateral collateral ligament with diffuse thickening of the ligament maintaining its normal signal. Two different examples of chronic injury of the lateral collateral ligament, and the ligament is of dark signal, but its caliber has much increased. Then we came to the syndesmotic complex, and this ligaments connect the fibula to the tibia, and they are identified whenever the fibular cross section looks oval in shape, like this one, and or let's say beer shape. Then if you look anteriorly, you will see the anterior tibiofibular ligament. If you look posteriorly, you will see the posterior tibiofibular ligament. There are a third component which is known as the inferior transverse ligament, which is just the deep fibers of the posterior tibiofibular ligament. Then, this is the anterior tibiofibular ligament identified when the fibula is oval in shape and it connects the fibula to the tibia. The posterior tibiofibular ligament connects the fibula to the posterior aspect of the tibia. And this is the normal appearance of the anterior and posterior, tibiofibular ligaments. You remember that the inferior transverse ligament is just the inner fibers of the posterior tibiofibular ligament. Then the anterior tibiofibular ligament is commonly injured, and injury means that you do not see the ligament and its site is replaced by fluid. Then we came to the anterior aspect. Anteriorly, we have only tendons like posteriorly, and we do not have ligaments anterior or posterior to the ankle. We have ligaments lateral and medial. The ligaments along the anterior aspect of the ankle are the extensor tendons, which are the tibialis anterior, extensor hallucis longus, and the extensor digitorum longus. All the three muscles are also represented posteriorly. And this is the tibialis anterior, this is the tibialis posterior. This is the extensor hallucis, and this is the extensor digitorum. Then it changed the position. This is the flexor digitorum, and this is the flexor hallucis. And you remember, these are the two peroneal tendons, the longus superficial, the brevis deep, and this is the tendo Achilles. Then there are three tendons, extensors anteriorly, tibialis anterior, extensor hallucis, extensor digitorum. The same posteriorly, but it changed the position between these two tendons, and this is the tibialis posterior facing the tibialis anterior, then flexor digitorum, and the flexor hallucis. This is the peroneus longus, peroneus brevis, tendo Achilles. Then the tibialis anterior may be injured, and you can see here the tendon is swollen and its caliber has increased with the abnormal signal within the tendon, and also the tendon is surrounded by fluid, meaning that the tendon has been injured. And this is the splitting of the tibialis anterior tendon. The tendon is split into two parts and is surrounded by fluid signal denoting tenosynovitis as well. Then we came to the posterior aspect, or let us say the posteromedial aspect, where you got the three muscles and the deltoid ligament. The three tendons are the tibialis posterior, the flexor digitorum, and the flexor hallucis longus tendons. Then the tibialis posterior tendon is one of the big tendons in the ankle. Its cross-sectional caliber is twice the flexor digitorum or the flexor hallucis. Normally, the tibialis posterior is twice in size the flexor digitorum or the flexor hallucis. Then tibialis posterior tendon may be injured, and the injuries are include three types. Type 1 injury means that the tendon has much increased in caliber, regardless if it contains abnormal signal or not. Just the swelling of the tibialis anterior tendon to become 4 or more times the adjacent flexor digitorum tendon, meaning that it is type 1 injury. Compared to the normal, this is the tibialis anterior normal, and this is the flexor digitorum and the flexor hallucis. The tendon here has much increased in size, together with abnormal high signal in both T1 and T2, denoting the presence of intrasubstance hemorrhage or tear. Type 1 injury of the tibialis posterior tendon means that the tendon caliber has much increased compared to the caliber of the adjacent tendon, which is the flexor digitorum tendon. And the tendon is also surrounded by soft tissue edema and granulation tissue. Another example of type 1 injury of the tibialis posterior tendon, the tendon caliber is too much increased compared to the flexor digitorum or the flexor hallucis tendons. And this is type 1 injury of the tibialis posterior. The tendon caliber has increased with fluid signal around the tendon, meaning that there is tenosynovitis, and this is type 1 injury of the tibialis posterior with tenosynovitis. In type 2 injury, the tendon is splitted into two halves. Then you compare this tendon by this one. This is the normal tendon, tibialis posterior, flexor digitorum, flexor hallucis. The tibialis posterior here is splitted into two halves. The flexor digitorum is surrounded by fluid, denoting the presence of tenosynovitis, and this is the flexor hallucis longus. The splitting of the tendon into two parts means that you are dealing with type 2 injury of the tibialis posterior. And here, two parts of the tendon is split by this abnormal signal, denoting type 2 injury. Another example of type 2 injury of tibialis posterior, and you got two halves of the tendon. This is the flexor digitorum and the flexor hallucis, meaning that you are dealing with type 2 injury of the tibialis posterior. Type 3 means that complete rupture of the tendon and you don't see the tendon and each side is replaced by fluid. This is the flexor digitorum and the flexor hallucis, but the tibialis posterior is not present compared to the normal appearance, tibialis posterior, flexor digitorum, and the flexor hallucis. And this is another example of type 3 injury, absent tendon. This is the marker put in the skin at the site of the patient complaint, and this is the flexor digitorum, flexor hallucis. The tendon is replaced by hemorrhage and edema. Tenosynovitis means that accumulation of fluid in the synovial sheath around the tendon, and this may be acute or chronic. The most common cause is trauma, sometimes inflammation or infections. And this is fluid signal around the flexor hallucis longus tendon, meaning that there is tenosynovitis. This is the fibula, anterior tibiofibular, posterior tibiofibular ligaments, and these are the two peroneal tendons, brevis and longus, surrounded by fluid, meaning that tenosynovitis of the peroneal tendons. In the anterior aspect of the ankle, this is tibialis anterior, flexor extensor hallucis, and extensor digitorum. The extensor digitorum is surrounded by fluid, meaning that there is tenosynovitis of the extensor digitorum. Now we came to the ligaments located on the medial aspect, and this is the deltoid ligament. The deltoid ligament is a complex ligament formed of many bands, and these bands go from the tibia to the calcaneus to the navicular bone and to the talus. The, the best way for evaluation of the medial collateral ligament is in the coronal images, where you see the classic fan shape appearance of part of the tendon coming from the tibia to the talus. Another part is coming from the tibia to the calcaneus. This part of the calcaneus is the sustentaculum tali, and there is one of the bands of the ligament going here. You know, the deltoid ligament is deep to the flexor tendons, the tibialis posterior, the flexor digitorum, and the flexor hallucis longus tendons. Then, this is the appearance of the deltoid ligament in the axial. It is better to evaluate the ligament in the coronal images, and you can see the bands of the ligament in the coronal coming from the tibia to the talus, coming from the tibia to the calcaneus. And this is the normal appearance of the medial collateral ligament with fan-shaped configuration coming from the tibia to the talus and from the tibia to the calcaneus. In order to diagnose injuries of the medial collateral ligament, the same rule applies here. You cannot see the ligament, and the site of the ligament is replaced by fluid. And you cannot see the fan-shaped configuration. You see the bone marrow edema in the talus, and these are signs of trauma. Also here at the site of the asterisk, you do not see the ligament, and the site of the ligament is replaced by fluid compared to the normal appearance of the ligament in this coronal T1 weighted image. Then few words about the sinus tarsi syndrome and the tarsal tunnel syndrome. What is the sinus tarsi? It is the space between the talus and the calcaneus. And this space is filled by fat, vessels, nerves, and two ligaments. The ligaments are one long, which is known as the cervical ligament, which attaches to the neck of the talus, and a shorter one, which is known as the interosseous ligament or the talocalcaneal ligament. Both ligaments are not usually seen in the same section, but they are seen individually, one in one section, and after another section, and you can see the second ligament. Then, how can you diagnose sinus tarsi syndrome? By number one, absence of the ligaments and the replacement of the fat by fluid. Fluid will appear dark in the T1 weighted image and bright in the T2 weighted image, the opposite of the fat. Fat will be bright here and dark here. What are the causes of sinus tarsi syndrome? Osteoarthritis is one of the common causes. Ganglion, gout, ligament tear, synovitis, as in cases of rheumatoid arthritis. The basics for diagnosis of sinus tarsi are torn ligaments, and you do not see the cervical or the interosseous ligament, diffuse inflammation with synovitis, and increased signal within the sinus tarsi, replacement of the signal of the fat by the signal of fluid. And this is the site of the sinus tarsi in the axial image between the talus and the calcaneus. And here in the T1 you see black signal, in the T2 you see bright signal, meaning that the fat is replaced by fluid. The sinus tarsi syndrome usually presents by lateral foot pain and tenderness. Scarring and the degenerative changes of the soft tissue structures in the sinus tarsi will lead to replacement of the fat signal by fluid. Then, this is an example of sinus tarsi syndrome. You do not see the ligaments, you see intermediate signal and the bright signal in the stir image denoting the presence of fluid. And this is also a sinus tarsi syndrome in a female 40 years old with ankle pain, sense of giving way and limitation of movement following episodes of ankle sprain. Then you see dark signal in the T1 and bright signal in the stir, meaning that there is fluid, and you cannot also identify the ligaments within sinus tarsi. Then we came to the tarsal tunnel, and the tarsal tunnel is formed by a bony floor and a soft tissue roof. The bony floor is made of this part of the calcaneus, which is known as the sustentaculum tali, and the talus, as well as the body of the calcaneus. The tarsal tunnel contains the flexor tendons, the tibialis posterior, the flexor digitorum, and the flexor hallucis, together with a neurovascular bundle. It is covered superficially by the flexor retinaculum and one muscle which is known as abductor hallucis muscle, or in abbreviation ABH. The small muscle is located in the floor of the tarsal tunnel known as quadratus plantae. This is the ABH, or abductor hallucis, and this is quadratus plantae. And this is the flexor retinaculum covering the flexor tendons running through the tarsal tunnel together with neurovascular bundle. What are the causes of tarsal tunnel syndrome? The causes are either intrinsic, meaning that development of masses inside the tarsal tunnel, and this may be in the form of ganglion cysts, varicose veins, neuroma, lipoma, sarcoma, tenosynovitis, and fibrosis. And here you can see ganglion cyst, which is of low signal in the T1 and high signal in the T2 with an image within the tarsal tunnel, resulting in tarsal tunnel syndrome. Also, this is the tibialis posterior, as you all know, and the tibialis posterior is surrounded by fluid, denoting that there is tenosynovitis, and tenosynovitis will result in of the flexor tendons, of course, will result in tenosynovitis, in tarsal tunnel syndrome. And this mass has been proved to be a giant cell tumor of the tendon sheath. It shows low signal in the T1 and the bright signal in the T2, and is totally occupying the tarsal tunnel. Then extrinsic causes that can result in tarsal tunnel syndrome include trauma with fractures, hypertrophy of the abductor hallucis muscle, the ABH muscle, or the bony coalition. The most common is the coalition between the talus and the calcaneus, and this is the normal appearance of the talus and calcaneus, and this is the coalition which will result in a bony protrusion that will encroach significantly on the tarsal tunnel. The most common subtypes are of tarsal coalition are the talocalcanean and the calcaneo-navicular coalition. And it accounts for 45% of all tarsal coalition, these two. The three facets of the talocalcanean joint can be involved, but the middle facet is most commonly involved. And you can diagnose talocalcanean coalition by this C sign, which is seen in the lateral ankle radiograph. Normally, there is a gap between the talus and the calcaneus, the talocalcanean joint. But in cases of tarsal coalition, the bone will be continuous to form a figure like the letter C. And if you can identify this C, and this is a good observation to suspect the presence of talocalcanean coalition. If you look normally here and you see the space or the joint space between the talus and the calcaneus, and here you can see the continuity of the bone across this joint. These are the facets of the talar surface. We have three facets: the medial, the anterior, and the posterior facet. The medial facet is commonly involved in this coalition, but the whole facets can be also affected. Here it is clear that you can see that the talus is continuous with the calcaneus posteriorly, and there is no joint space here, meaning that there is coalition. You see, this is the joint space in a normal ankle lateral radiograph, and here you cannot see the space with continuing bone across the region of the joint. By CT, it's easy to see. This is the normal appearance, the joint space, and here you can see coalition with bony protrusion or bony mass encroaching on the tarsal tunnel. Also here you can see loss of the joint space between, this is the normal appearance of the joint space between the talus and the calcaneus. Here you can see the joint space is almost totally obliterated, and you see the prominence, the bony prominence encroaching on the tarsal tunnel. Calcaneonavicular coalition can also occur, but it will not significantly affect the tarsal tunnel. And you see, this is the navicular and this is the calcaneus. This is fibrous coalition, which will later on form bony coalition. هذا وبالله التوفيق والحمد لله.